Hello everybody, I'm Dr. Meenakshi, and in today's video I'm going to be discussing a very important topic which is on the cervical cancer in pregnancy. I'm going to be discussing only about management. The entire guideline regarding the cervical cancer in pregnancy would also be uploaded shortly. So I post MRCOG related videos on my YouTube channel. So please do subscribe to my channel for more content. And if you wish to want to learn about anything new or to simplify any of the topics, I'm open to the suggestions, and please do let me know in the comments below, and I'll be making the videos on them as well. So mostly I would be posting only the short videos wherein you can get emphasis on that particular subject. But if you wish to want any other subject or any long videos, short videos, whatever is your preference, you can let me know in the comments, and I'll be more than happy to make videos on them. So cervical cancer in pregnancy, this is a bit tricky topic, and it's a bit confusing too, because we don't do it on in and out on a daily basis, so it can be a bit confusing, and I hope that it gets simplified by the end of this session. So this is mainly based on the top article of cervical cancer and pregnancy. So without further ado, let's get started, and let's see only about the management, and the entire cervical cancer and pregnancy would be covered in the next videos. So basically, before you understand about the management of cervical cancer, it is very important that you have to be well versed with the staging of the cervical cancer, which is the FIGO 2018 classification, which is very important. So stage 1 to stage 4, where you're supposed to learn each and everything, and it can be asked as questions, which is also important to MRCOG part 2, and because stage based management could also be asked, and sometimes you'll be just giving a description of the particular scenario where you have to guess the stage as well. And similarly for MRCOG part 3 also, there could be a station where they'll be giving about the spread, etc., where you have to understand what is the staging. So it's important that you have to memorize, and it's not conceptual, it's completely memory based. So you have to be ensuring that you please read about the staging of the cervical cancer. So firstly, we have got, as I told you, stage 1 to stage 4. So stage 1 means that is restricted only to the cervix, right? So in this, again, we have got 1A as well as 1B. And again, 1A is divided into 1A1 and A2, and again B is divided into B1, B2 and B3. That is mainly based upon the extent. So when I say 1A, it means that there is the diagnosis which is made only on a microscopy, whereas 1B means it is clinically visible. And when you talk 1A, when it is about microscopy, it only measures in terms of the depth of the invasion. So stage 1A1 is less than 3 mm in depth. So 1A2 will be between 3 mm and 5 mm, but it has to be less than 5 mm in depth. And whenever the depth goes by more than 5 mm, that would be classified under 1B. And again, based on the size of the tumor, that becomes as 1B1, B2 and B3, which is less than 2 centimeters, 2 to 4 centimeters and more than 4 centimeters respectively. So firstly, coming to the stage 1A1. As we can see that stage 1A1 means that is just it is found to be on your microscopy, as I have discussed. So in this, again, we have got two different varieties, whether there is a lymphovascular invasion which is present or not. So basically, the lymphovascular invasion, it is the involvement of the lymphovascular spaces. So when there is a no lymphovascular invasion, in such cases we can go for a cone biopsy, and this cone biopsy can be done between 14 to 20 weeks of gestation. But if the margins come out to be positive, a second treatment might also be required. And in this case, we can aim for a vaginal delivery. And the risk of pelvic lymph node metastasis is less than 1%. So therefore, the pelvic lymph node dissection is not required in this stage. Now, this is the very minimal stage, stage 1A1, where there is less than 3 millimeters in depth. So for this, the lymph node dissection is not required because the chances of lymph node metastasis is less than 1%. So that reason, it is not required. And the treatment is going to be cone biopsy. So just remember that for 1A1, it is going to be cone biopsy, and ideally it is performed between 14 and 20 weeks of gestation. And then we've got 1A1 where there is a lymphovascular invasion, or we've got 1A2. As I've told previously, 1A2 means there is slightly more depth, which is about 3 to 5 mm in depth. And then we have got 1B1. 1B1 means it is less than 2 centimeters in the greatest dimension, as I've told previously. So for all of these, now since the staging is getting upgraded, now what you have to do is it is mainly based upon the gestational age, whether they are less than 22 weeks or whether it is more than 22 weeks. If it is less than 22 weeks, then what are we going to do? we have to do a staging lymphadenectomy. So please remember that after 22 weeks, staging lymphadenectomy cannot be performed because the size of the gravid uterus, it keeps enlarging. So therefore, the gravid uterus is big after 22 weeks, and secondly, the surgery becomes more riskier at that particular age, and the chance of getting the lymph nodes retrieval is also very minimal. So that's the reason we do not perform any lymphadenectomy once you cross 22 weeks. And if it is less than 22 weeks, you do a staging lymphadenectomy. Now, once lymph nodes are got, the result is again of two categories. Either it is positive or if it is negative. If it is positive means what? That means that lymph nodes are involved. When the lymph nodes are involved, that means that is directly coming under stage 3 because there is a lymph nodes involvement, is it not? So in that cases, you'll have to be going for a termination of pregnancy. Whereas on the other hand, if it is negative, you can go for a simple trachelectomy, or you can also delay the treatment after delivery. Even that is also possible. And this again, the decision whether you wish to take the treatment or whether you can delay it after delivery, that is all dependent upon the woman's preferences as well as even the MDT decision, that is the multidisciplinary team decision. And once you cross 22 weeks, you can go for the neoadjuvant chemotherapy, or you can also delay the treatment after delivery, since I've told you that we won't be performing a lymphadenectomy once you've crossed 22 weeks. But the ideal treatment for stage 1B1 and 1B2 is going to be radical hysterectomy with pelvic lymphadenectomy, with bilateral salpingectomy, and the ovarian removal, of course, would be dependent upon the MDT decision, where you have to discuss with the woman about the preservation versus removal, what all challenges can be expected. So actually, the ideal treatment is to go for a hysterectomy with pelvic lymphadenectomy. But we can do these conservative management, that is, you can delay it after the delivery, or you can go for the chemotherapy. The neoadjuvant chemotherapy can be given. Now, since she's in the second trimester, you could give it. That helps in also the downstaging of the tumor. Okay, so what is this trachelectomy? In this trachelectomy, we've got again two different kinds. One is a simple trachelectomy or the radical trachelectomy. So simple is we remove the cervix, whereas in radical trachelectomy, the cervix is removed, the upper part of the vagina is removed, the parametrium is also removed, and the uterus as well as the vagina, they would be, again, there is an anastomosis which is created between them. And normally the trachelectomy is also not recommended by the British Cancer Society during the pregnancy, because there is an increased risk of having preterm birth, which is happening in around 20 to 30%. And also a lot of expertise is required for performing this procedure. And once if you're performing the trachelectomy, okay, and in case you're performing the trachelectomy, it's important that from 16 weeks onwards, you will have to be screening for the genital infections, and prophylactic antibiotics needs to be given. And whenever you're performing the trachelectomy, that means the cervix is removed. So therefore, a cerclage needs to be performed routinely. And then we have to be discussing about the antenatal corticosteroids, which has to be taken from 24 weeks onwards. We have to have a discussion because there is a risk of preterm, which is about in 20 to 30%, which can also be an important number for part 2 MRCOG. And what we do is since this procedure is being performed, it's better that you have to do a planned pre-labor cesarean section. That is important to avoid the risk of having a uterine rupture as well as to prevent the risk of having a major hemorrhage. So these are the important points that you should remember whenever you're counseling about the trachelectomy. Now we move to the next stage. That is, we have finished 1A1 as well as A2. 1A1 again with and without lymphovascular invasion. 1A2 is also completed, and we finished 1B1 as well. Now 1B2. B2 means the tumor sizes between 2 and 4 centimeters, the greatest dimension. So again, less than 22 weeks, the similar story, that is, we can perform a lymph node dissection, and you give the option of continuation versus termination of pregnancy, right? So if she is willing to continue the pregnancy, you have to talk about the neoadjuvant chemotherapy. And if there is a termination of pregnancy, so what we do if there is, since there is an upgradation of stage, the tumor is large enough, like 2 to 4 centimeters, Leeds procedure or trachelectomy, they're not suitable. So we can do a radical hysterectomy with pelvic lymphadenectomy with the fetus in situ. Okay, that is going to be the mainstay of treatment in case she is less than 22 weeks of gestation. And then if she has crossed 22 weeks, you have to give the neoadjuvant chemotherapy, and then you delay the treatment after delivery. That means whenever you're performing a cesarean section, when the fetus maturity has been attained, we usually perform it between 34 and 36 weeks of gestation, that can be done. And along with the cesarean section, you perform a hysterectomy along with the lymphadenectomy. So that is about 1B2. As I've discussed in the previous slide as well, that for 1B1 as well as B2, it's radical hysterectomy that is going to be a gold standard management. If it is less than 22 weeks, you perform it while you're terminating the pregnancy with the fetus in situ. And if they've crossed 22 weeks, it's better that you carry on to the third trimester, and then you can perform a cesarean section. Along with that, you do a hysterectomy. And next we have got stage 1B3. B3 means that the tumor size is more than 4 centimeters in the greatest dimension. So therefore, since there is this is going to be like a bigger size when it is more than 4 centimeters, and obviously anything above that, stage 2, 3 and 4 is going to be bigger than that. So regarding the lymph node dissection, it is still questionable whether you want to perform a lymph node dissection or not. And similarly, less than 22 weeks, you give the option of both neoadjuvant chemotherapy or the termination of pregnancy. And once you cross 22 weeks, you can go for the neoadjuvant chemotherapy. And when you perform the delivery, you can do an LSCS with radical hysterectomy, or even a chemoradiotherapy can also be offered to the woman. It is seen that both the hysterectomy as well as the chemo radiation, both of them, the risks as well as the success rates are found to be like similar for both of them. So it is the woman's choice, whichever she wishes to undergo. Like after the delivery, if she wants to go for the chemo radiation, you could do that as well. And otherwise, a surgery of radical hysterectomy could be performed. That is for 1B3 as well as above. Once they're continuing the pregnancy and when the chemotherapy is being performed, as I've discussed, it is important that we deliver between 34 and 36 weeks of gestation in order to avoid any iatrogenic prematurity. If early delivery is indicated, then it's important that you involve the neonatologist. Suppose in the interest of mother's health, if you think that you will have to go for an early delivery, please make sure that the neonatologist should be available. So let us have a crisp outline which is taken directly from the talk article. This is again a crisp outline of just whatever we have discussed. Okay, so the staging is dependent not just on the biopsy findings, but you have to have an entire investigations like doing an MRI as well as an ultrasound, abdomen, pelvis. And in the pregnancy, CT is not preferred. You can go for a chest x-ray, and CT, because there is a risk of radiation, it is not preferred. Rather we go for an MRI, and ultrasound can be done. And of course, whenever there is a biopsy, that is also going to be adding up to the stage where you can take these findings as well. And 1A1, as I told you, you have to go for a cone biopsy, and then you can go for a vaginal delivery. Supposingly it is about 1A2 and 1B1, and then we have got 1B2 and 1B3, right? Anything wherever you have crossed 22 weeks, just remember that it's going to be chemotherapy, neoadjuvant chemotherapy, and then delay, or you can delay the treatment after delivery. That is along with the cesarean section. It is better that you perform a radical hysterectomy. So what happens is, when you're performing a cesarean section, initially they used to say that you have to go only for an upper midline incision, but now even a transverse incision can also be given. That is also an important point that you should be remembering. But of course, they need to have a lot of expertise while performing this surgery. Okay, and once they are less than 22 weeks, if they're less than 22 weeks, up to stage 1B2, you can perform the lymph node dissection. And based on whether it is positive or negative, you either give the termination of pregnancy if it is positive. So these are two keywords which are common to everything. That is, after 22 weeks, you offer chemotherapy or you delay the treatment after delivery. And secondly, in under 22 weeks, whenever you're performing the lymph node dissection, if the lymph nodes come out to be positive, you have to offer the termination of pregnancy. If the lymph nodes are negative, up to stage 1B1, that is until it is less than 2 centimeters, you can go for a simple trachelectomy or delay the treatment after delivery. 1B2 means the stage is going to be between, the size is going to be between 2 and 4 centimeters. So therefore, you can go for a neoadjuvant chemotherapy or delay the treatment after delivery. And similarly, even for 1B3, that is going to be a similar case. Only for 1B1, up to 1B1, you can perform a simple trachelectomy. And anything above that, you will be going for chemotherapy, and following that, you can also delay the treatment after delivery. And regarding chemotherapy, of course, it is found to be contraindicated during the first trimester of the pregnancy. That is very important, because it is found that there is a risk of having major malformation. So it is completely safe when you give it after 14 weeks of gestation. And whenever you're giving the chemotherapy after delivery, also the breastfeeding is found to be contraindicated. So therefore, you cannot breastfeed on chemotherapy. So what they say is, whenever you're planning for a cesarean section, okay, you have to allow at least 3 weeks of gap between the last chemotherapy cycle as well as the cesarean section. This allows the recovery of the bone marrow, both the mother as well as the fetus, right? And we have carboplatin and paclitaxel regimen as well as cisplatin and paclitaxel regimen, but it is better you go for carboplatin because it is found to be less nephrotoxic as compared to that of cisplatin. So therefore, you could prefer that regimen. And maximum you can do is up to 35 weeks of gestation. You can continue this, beyond which it's not required, because sometimes they might also be landing into preterm labor. So to allow that gap for the recovery, it is important that you allow at least 3 weeks, or at the latest is that you can stop it by 35 weeks of gestation. But as such, there are no mega trials which has been performed on chemotherapy in the pregnancy. And then we have got the radiotherapy. So radiotherapy, once we have crossed 1B3, as I told you, like 1B3 and above, okay, both the surgery as well as radiotherapy, they are both having equal weightage. So after the cesarean section, you can perform the radiotherapy, but taking her fertility opinion is very, very important. What is her fertility intent? What are her plans for future pregnancy is important, because post radiotherapy, the uterus might not support a pregnancy well. That is something that she needs to understand. And secondly, even when you perform an ovarian transposition also, in the before the radiotherapy, there is an inherent risk which the ovaries are exposed to. So therefore there could be transient or premature ovarian failure, and they might be requiring surrogates after this, because the uterus does not support, and because of the radiation there could be fibrosis of the uterus. So these are the points that you need to counsel the woman if she is undergoing the radiotherapy after a cesarean section. And of course, whenever there is any premature ovarian insufficiency, or when the ovaries are being removed at the time of hysterectomy, then it's important that you will have to be counseling regarding the hormone replacement therapy to the woman as well, until she reaches the natural age of menopause, right? And these were certain important points which are related to the management of cervical cancer in pregnancy. I hope you found this video useful. If you like this video, please do subscribe to my channel, and also let me know in the comments below if you've got any doubts, and I'll be happy to clear them. And in case you want to have a discussion on any other topic, I'm open to that as well. And I will see you all in another video. Until then, take care and bye.